Infectious diseases. Varun Phadke is an assistant professor in the division. He's also the associate program director for our fellowship program and already a very celebrated teacher in our system. I think he is a future star in medical education for the university. So today he's going to talk to us about a topic we were asked to present because there's a lot of interest in it, and there can be frequent places for confusion in adult medicine. We're not always so good at vaccines. So he's going to talk to us today about immunizations and give us some updates for the internists. So welcome, Varun.
Thanks, Monica. I will be talking about some kind of very practical, but also some kind of scientific background to updates in immunizations for general internal medicine. So I have no conflicts of interest. So I have three specific learning objectives for this presentation that are kind of largely driven by the content of the presentation. But before I even get into that, I have some kind of big picture objectives as an educator. My goals sort of for this session are to kind of give you guys some practical tips about how to think about vaccine decision making for individual patients, to give you guys some scientific background for how those decisions are made, but also how public health officials make decisions about vaccine policy, and then finally to kind of give you a flavor for some recent papers that are very interesting and I think have shed some novel insights about disease epidemiology and vaccine design. So my first objective is to talk about protein conjugate vaccines. We'll be talking about their immunology and their performance and how they've impacted disease epidemiology, focusing specifically on pneumococcal conjugate vaccine in adults. The second objective will be to talk about a concept called vaccine failure, both defining it, its mechanisms, how we overcome it, and using influenza vaccine, whose performance varies often from year to year, as a case study in vaccine failure. And then finally, we'll talk about adjuvanted vaccines, both what adjuvants are, which adjuvanted vaccines are available, and focusing specifically on the new recombinant herpes zoster vaccine as a case study in adjuvants. So this is just a timeline to summarize the introductions of vaccines into the adult immunization schedule since the schedule was first created in 2002. And you can see that there's been kind of a flurry of activity in the last 5 years with a lot of new vaccines added to the adult schedule. And so I'm going to be talking about a lot of the vaccines that were just introduced in the last 3 to 4 years, specifically PCV13, the recombinant zoster vaccine, and the hepatitis B vaccine. So I wanted to start out with a clinical case just to set up kind of, or to frame my discussion, and that was sort of advised by the Grand Rounds Committee. So this is a common kind of bread and butter case that I'm sure all of us encounter all the time in our clinics. A 65-year-old woman comes to your clinic in October for a routine follow-up. You dutifully navigate your way through her many complaints, her chronic diabetes, hypertension, GERD, and at the end of that 20 minutes, you realize that she's eligible for several vaccines. But as is always the case in internal medicine, there are several problems. You want to give her the pneumonia vaccine, and she says, oh yeah, I got a pneumonia vaccine a few years ago. There's another one now. You want to give her the flu shot, and she says, I got the flu shot last year, and I still got the flu, so why should I get it again? And you want to give her the zoster vaccine, and she says, that vaccine is sold out everywhere. Should I still get it? So I have divided my talk into 3 parts because every talk in medicine has to be divided into 3 because it's good for knowledge retention. And so in the spirit of that, I sought to get some inspiration from classic movie trilogies. So these are kind of trilogies going back over the last 5 decades because I knew that the age range of this audience would be relatively broad. So hopefully one of these will resonate with you. And if you actually look at movie trilogies in this kind of long view, you recognize some themes. So the first part of every trilogy is the same. There's some sort of initial success, but it's pretty short-lived. And that's what brings us back for part 2, which is some sort of serious setback for our major characters. And that's what brings us back to part 3, where there's some heroic finale, where our characters have come to some deeper understanding about themselves or the universe. And so I have modeled my talk in this vein. I'll be talking about conjugate vaccines, why vaccines fail, and adjuvanted vaccines. So let's talk about protein conjugate vaccines. So I want to tell you about what is a conjugate vaccine and why we need them. what impact they've had on disease epidemiology, and how we should use them, specifically focusing on pneumococcal conjugate vaccine. So just to give you a little bit of a review of some basic immunology. So vaccination, you will remember, is deliberate administration of an antigen with the goal of generating protective immunity. So this antigen can be a peptide or a non-peptide. And for the purpose of the next few slides, I'm going to depict peptide antigens as a yellow triangle and polysaccharide antigens as a green triangle or a green star. So we kind of classically dichotomize vaccine-induced immune responses into T-dependent and T-independent responses, depending on the type of antigen involved. So for peptide antigens, this is a T-dependent process where the antigen can be recognized by both B and T cells. T cells have to recognize the antigen through presentation by MHC. Recognition of the antigen leads to clonal proliferation of these lymphocytes. Activated B cells then can present that antigen to T cells, leading to upregulation of CD40 ligand, which then stimulates the B cells to migrate to the germinal center. So the germinal center is the special place inside lymph nodes where B cells and T cells interact, and B cells undergo this important maturation process of somatic hypermutation and affinity maturation, the goal being to produce these highly select B cells that are producing high affinity, high quality antibodies. And with further help from T cells, those B cells then further differentiate into antibody-producing plasma cells and memory B cells that can produce antibody if they encounter the antigen a second time. In contrast to this, T-independent responses, for example, in response to a polysaccharide antigen, there is no involvement of the T cell because the T cell cannot be stimulated by a polysaccharide antigen. So only the B cell is stimulated to proliferate. The B cell cannot present antigen to the T cell counterpart, so there's no germinal center reaction. B cells have to undergo extrafollicular maturation, and they still end up producing antibodies, but they tend to be of lower quality and lower number. So just to compare and contrast the final outcome of polysaccharide and protein antigens, you can see that protein antigens have a number of advantages in the sense that they produce a higher number of antibodies, higher quality antibodies, and a greater breadth of antibodies. So this is important because there's a variety of antigens that we encounter on a regular basis that are not protein antigens. And these are some important non-peptide antigens for human health. And specifically, I'm going to highlight encapsulated bacteria, including Streptococcus pneumoniae, Neisseria meningitidis, and H. influenzae, 3 important causes of human disease worldwide. And these organisms possess a polysaccharide capsule, which is the presenting antigen for our immune system. And so this T-independent pathway is a suboptimal way of managing these organisms. So you'll recall that the polysaccharide capsule evades our immune system by resisting complement and phagocytosis. And so we require anti-capsular antibodies to engage these arms of the immune system in order to eliminate these infections. So in order to generate these anti-capsular antibodies through a T-dependent mechanism, this is the rationale for glycoprotein conjugate vaccines. So glycoprotein conjugates are essentially a synthesis of polysaccharide antigen to a carrier protein. And the goal then is that the B cells can recognize the polysaccharide component of this antigen and then present the peptide component to their counterpart T cells, thus stimulating the germinal center reaction, leading to the generation of high-quality antibodies against specifically the polysaccharide capsule. So this technology has allowed us to develop very high-quality vaccines against these encapsulated organisms, and pneumococcal vaccines being a case study for this presentation. So to give you a sense of how much of an impact this vaccine has had, the first pneumococcal conjugate vaccine, PCV7, that was introduced into the U.S. schedule was for children in the year 2000. And its direct effects, meaning vaccinating children and the impact in those vaccinated children, were quite remarkable. So you can see the massive reduction in invasive pneumococcal disease that was seen immediately after the introduction of PCV7 in children. So the red line in this graph are the serotypes covered by the PCV7 vaccine. And you can see that almost immediately after introduction, those serotypes vanished from pediatric disease epidemiology. And you can see a similar decline after the introduction of PCV13 vaccine also in children. Now, it's important to understand that part of this decline was also due to indirect effects, because even children who were not vaccinated were having declines in disease. And that's because these conjugate vaccines lead to the generation of mucosal immunity through IgA, and that leads to decrease in nasopharyngeal carriage of these encapsulated organisms. And so disease transmission between children and even from children to adults is impacted by vaccinating just children. And you can see that if you look at the impact of pediatric vaccination on adult disease as well. So you can see that in 2000, we introduced PCV7 in children, but there was a corresponding decline in PCV7 type pneumonia even in adults over the age of 65, which is illustrative of this kind of transmission dynamics between children and adults. So this is sort of one of the big kind of advantages of protein conjugate vaccines, which is this mucosal immunity. So this is one interesting study that kind of looked at this interaction from kind of the spatial resolution of this interaction. So this was an interesting study done in Connecticut where the investigators looked at the proportion of children who had completed their pneumococcal vaccine series and the proportion of adult cases of vaccine-specific, serotype-specific pneumonia in the zip code corresponding to where the children had or had not gotten vaccinated. And you can see basically a nice association where the more children in your zip code that have gotten pneumococcal vaccine, the fewer adults in that same zip code get vaccine serotype-specific pneumonia. So the conclusion from this is that it's important for grandma to get her pneumonia vaccine, but it's probably more important that grandma's friends, relatives, and neighbors' kids all get the pneumonia vaccine first. So it stands to reason that if giving children the vaccine is so beneficial, that there might be added benefit to giving adults the protein conjugate vaccine. So that prompted this large randomized controlled trial in the Netherlands in 2013, or take that back, 2008. The investigators in this study found an efficacy of 45% for PCV13 against vaccine serotype-specific pneumonia, which was pretty dramatic. So it was based largely on the results of this large clinical trial that the ACIP recommended in 2014 to give PCV13 vaccine routinely to all adults over the age of 65 in the United States. So that brings us back to the clinical case where our patient tells us, oh yeah, I got a pneumonia vaccine a few years ago, which probably was the polysaccharide vaccine. And so that brings us to a very common clinical dilemma in our clinics, which is, which pneumonia vaccine would you give to this patient? So you guys can log into Poll Everywhere by going to that website on your mobile device, or you can text my name 928 to that number, and then answer using A, B, or C. So while you guys do that, I can tell you that the reason I asked this question, which seems relatively straightforward, is that the pneumococcal recommendations are quite complex. There's only 2 vaccines available, yet the amount of information from ACIP about which vaccine to give is extraordinarily long, and I spent a lot of time with it last night. So this is not necessarily a straightforward question based on the patient's comorbidities or prior vaccination history. Can you guys see it? Oh no. How did those 2 people break in? Oh, that's weird. Well, both of you said the correct answer, which is pneumococcal conjugate vaccine. Great work. It is active. That's weird. That's okay. So these are the detailed guidelines from ACIP about how to make a decision about which pneumococcal vaccine to give your patient. And so There is scientific rationale to both the sequence and the intervals that are recommended by ACIP for which pneumococcal vaccine to give first and how long to wait before giving the second one. So order and spacing actually has an important impact on your response to the vaccine, and that's the rationale underlying the recommendations. So, for example, if you give the polysaccharide vaccine first and then give the conjugate vaccine shortly thereafter without an appropriate interval, you might actually have a blunted antibody response and not gain any benefit from the conjugate vaccine that you are administering. In contrast, if you give the conjugate vaccine first and then give the polysaccharide vaccine, you can actually have an enhanced antibody response, and this is why this is the sequence recommended by ACIP. In fact, leaving a longer interval in between the conjugate vaccine and the polysaccharide vaccine is associated with even better antibody responses, and the shorter the interval, the more reactogenicity is observed at the injection site. And so currently the recommendation is to wait a year between conjugate vaccine and polysaccharide vaccine for immunocompetent adults over the age of 65. So just to give you an illustration of this phenomenon, so this was a study actually of meningococcal polysaccharide vaccine, but this was a really nice graph that I thought illustrated the point well. So this concept of hyporesponsiveness, which is that if you give polysaccharide vaccine first or you give multiple doses of polysaccharide vaccine, you end up blunting the antibody response to the vaccine, thus canceling out any positive effect that you're hoping to achieve. So in this study, the investigators gave patients meningococcal polysaccharide vaccine, and in this graph, on the x-axis is days after they got that vaccine, and on the y-axis is their antibody response. And the different curves are the different populations that were vaccinated. So the green curve is people who had previously received a conjugate vaccine, so they had a nice, strong antibody response. The blue curve represent people who had never received any vaccine before, and you can see that they had a nice response, but that getting the conjugate vaccine first was even better. Whereas the people who had previously received a polysaccharide vaccine actually had a blunted antibody response to their subsequent polysaccharide vaccine. And this is why leaving an appropriate interval in between the last polysaccharide vaccine that the patient has had and their conjugate vaccine now is so important. So if we go back to the ACIP recommendations, these are now from 2014. If you go carefully into the document, you'll find this additional statement which says the recommendations for routine use will be revisited in 2018 and revised as needed. And this is one of the few times that the ACIP has put a time-limited recommendation on any vaccine. And it's good for us to sort of think about why this might be the case. Because for the last 4 years, the ACIP has very thoughtfully been collecting important data to help inform the decision about what to do for PCV13 and adults. So here are some limitations to continuing this strategy. So the first is that the efficacy data on which the decision was made may not necessarily be easily generalizable to the United States. So the study in the Netherlands had only just introduced pediatric conjugate vaccine prior to the initiation of this randomized trial. And I already showed you that pediatric vaccination can have a massive indirect effect on adults. So if you're not giving children pneumococcal vaccine, then of course administering the vaccine to adults could have a bigger impact than in a country like ours where we have routinely been vaccinating children against pneumococcus. The second major limitation is that this study excluded immunocompromised adults, and they defined immunocompromised as particularly broad. So anyone with any history of malignancy was excluded, people with HIV infection were excluded, and importantly, people with prior pneumococcal vaccination were also excluded. And so this excludes a gigantic swath of the people that we see in our clinics all the time. And so whether the additional benefit of giving our patients PCV13 is not very clear. So the other issue is that, as I showed you, the incidence of vaccine-type pneumococcal carriage and pneumonia in our population as a result of pediatric vaccination may be quite different from a place like the Netherlands because of these indirect effects. So this is a study looking at actually the 7-valent pneumococcal vaccine, comparing pre-vaccine and post-vaccine carriage of pneumococcus in the nasopharynx of children under the age of 5 and in adults. Now, the children are the ones getting vaccinated and the adults are not. But you can see, going from the dark bar, which is pre-vaccine, to the light gray bar, which is post-vaccine, that in both children and adults, after the introduction of pneumococcal vaccine, carriage decreased of vaccine-specific serotypes, and carriage increased of non-vaccine serotypes. This is the concept of serotype replacement that has been described for these conjugate vaccines. But this is relevant because if we've been vaccinating children with PCV13 for several years, it's quite possible that the carriage in children and adults is now of non-vaccine serotype, so giving adults PCV13 vaccine may not provide that much additional benefit. So the CDC kind of led an adult pneumococcal carriage study, and some of the results of that study were presented actually at the ACIP meeting a year ago. And this is one of the figures from that presentation. And in the yellow box, they basically were swabbing community-dwelling adults looking for pneumococcal carriage prevalence. And in the yellow box here, you can see that pneumococcal carriage prevalence in this particular population was remarkably low, so less than 2% pneumococcal carriage prevalence. And vaccine-type prevalence was 0.2%. So if this is the prevalence of vaccine-type pneumococcal carriage, what additional benefit are we hoping to achieve with PCV13 vaccination in this population? So perhaps the most important evidence kind of making us wonder about the effectiveness or the utility of continuing routine PCV13 vaccination in adults is looking at studies of pneumonia. So this is data from the EPIC study, which was a prospective observational study of community-acquired pneumonia in 2 centers in the United States, where basically patients who were being hospitalized for community-acquired pneumonia had a massive workup done looking for the microbial etiology of their pneumonia. In that study, approximately 5% of their patients ended up having pneumococcal pneumonia. It was the most common bacterial etiology of pneumonia. Probably the most kind of important finding from that study is that the leading cause of pneumonia was actually viruses. But pneumococcal pneumonia was the leading bacterial pathogen, accounting for 5% of all of the pneumonia in that study. And the investigators went on to then look at the specific serotypes of pneumococcus that were causing pneumonia in those patients. And this is that data. And you can see this study was done in 2010 to 2012. And you can see that there is essentially very little PCV7 type pneumonia. So PCV7 had been given to children starting in the year 2000. So after a decade of that vaccine in children, there essentially was no pneumonia in adults related to serotypes covered by that vaccine. In contrast, the vast majority of the serotypes that were causing pneumonia in this adult population were serotypes either in PCV13 or not in either vaccine. And this study was done before we had started vaccinating children with PCV13. So you can imagine that after we started vaccinating children with PCV13 in 2010 and 2011, it's quite possible that a lot of the adult pneumococcal pneumonia that we see now is not due to serotypes that would be covered by PCV13. And so the additional benefit of giving that vaccine to our patients is less clear. So this is just to summarize the fact that what I've been talking about is that this indirect effect may be the principal mechanism by which we reduce adult pneumonia, not adult vaccination. So just to give you a sense of how much this field is evolving, so the ACIP meeting is actually tomorrow and Thursday, and this is the draft agenda for tomorrow. And I just wanted to point out that pneumococcal vaccines are actually the number 2 item on the agenda, where they'll be discussing a lot of the data and kind of points that I have just made over the last 20 minutes or so. And there'll likely be a vote on pneumococcal vaccines in the coming year, I would imagine. So just some take-home points for just this section of the talk. So protein conjugate vaccines overcome this T-independent pathway of immune response. The pneumococcal conjugate vaccine has had a dramatic impact on disease epidemiology in children and adults. But the benefits of adult vaccination are a little bit harder to define, and recommendations regarding routine use of that vaccine in our population will evolve over the next 6 to 12 months. So let's move on to the second part of the talk, which is why vaccines fail. So I want to talk to you about how we define vaccine failure or how to characterize it, some strategies that we use routinely for overcoming it, and then we'll talk about influenza vaccine as a case study in vaccine failure. So before I talk about vaccine failure, which is actually a subset of this concept of immunization failure, it's worth kind of remembering that the vast majority of immunization failure worldwide is actually a failure of delivery of vaccines. Okay, so most vaccines, or actually all vaccines, are effective, but they're 0% effective if you don't give them appropriately, or if you don't give them at all. And there's many reasons why the delivery of vaccines might fail. It might be because of vaccine policy. It might be because vaccines aren't available. It might be because the quality of vaccines is poor because of disruptions in cold chain. It might be because there's problems in administering the vaccine properly, or not administering the vaccine at all because of provider or patient behavior. So this is the vast majority, this constitutes the vast majority of immunization failure worldwide. And it's important to remember this and prioritize our efforts towards fixing this. But vaccine failure is a subset of immunization failure, and this is where we actually are able to deliver the vaccine successfully, but it nevertheless fails to induce protective immunity. And this could be because of both vaccine factors and host factors. So let's focus in on vaccine failure a little bit. And so the ideal scenario is a vaccine that's given once or twice that induces protective immunity that is then very durable and lasts basically your whole life. And a good example of this would be measles vaccine, which induces lifelong protective immunity in the vast majority of individuals. Primary vaccine failure is where you give the vaccine, but there is essentially no immune response. And the situation in which we encounter that most frequently in our population would be hepatitis B vaccine, for example, where we give the vaccine and the person has not developed the appropriate antibody response to the vaccine after a standard dosing series. In contrast, secondary vaccine failure is where you mount an initial immune response, are protected, but then that response wanes over time to the point where you are no longer protected from that pathogen. And most recently, the vaccines that have been publicized as having secondary vaccine failure are the mumps vaccine and pertussis vaccine. So let's focus in a little bit about hepatitis B vaccine. So about 5 to 10% of individuals will not mount a protective immune response to hepatitis B vaccine, despite a standard dosing series of the currently available hepatitis B vaccine. And our standard approach to this is that we, the vast majority of people, we don't actually check post-vaccination titers because it's not recommended. But in the groups in whom we are expecting a higher than average rate of non-responsiveness, for example, immunocompromised patients or patients on hemodialysis, it is recommended to check post-vaccination titers because of this phenomenon. We also recommend checking post-vaccination titers in people who have an ongoing risk of hepatitis B acquisition, so healthcare workers, for example. And in people who do not respond appropriately, we recommend revaccination, and oftentimes we recommend revaccination with an alternate or more immunogenic formulation, so a higher dose of the vaccine, and more recently, an adjuvanted form of the vaccine. In some, though not recommended formally by ACIP, in some immunocompromised populations, for example in HIV, it has been suggested by experts to start with these more immunogenic formulations to overcome this non-responsiveness phenomenon. So mumps vaccine is a great example of secondary vaccine failure in that it induces protective immunity for a certain amount of time, but we have now seen increasing outbreaks of mumps among college-age students, suggesting that the immunity has waned over time. So this is just a map of the United States from the CDC website from a few days ago, showing the mumps outbreaks that have been reported to CDC just in the last 9 months, and there have been hundreds of cases. Most have been concentrated in college campuses, though there have been some well-publicized cases in the National Hockey League as well. And mumps vaccine, so there's been a lot of interest in figuring out why mumps vaccine is failing. I can tell you that it remains incompletely characterized. There's some thought that maybe it's because of inadequate cross-neutralization of the currently circulating mumps virus strains by the antibodies induced by the live attenuated mumps virus in the vaccine. But more likely is that the antibodies to mumps wane significantly faster than the antibodies to measles or rubella, which are contained all in the same vaccine. So the bottom line is that we just need a better mumps vaccine. But for right now, the strategy based on recent evidence is that in the setting of an outbreak, we should really just administer a third dose of MMR to boost those individuals' immunity. And these are patients that we might be seeing in our clinic because these are people who are college age or just out of college who are newly susceptible to mumps because their immunity has waned. So you can't talk about vaccine failure or lack of vaccine effectiveness without talking about influenza vaccine. And this is a conversation that we are having basically all the time in every single clinic between October and February, which is you tell the patient, I suggest the flu vaccine, and the patient tells you, well, I got the flu vaccine last year and I still got the flu. Now, notwithstanding the massive confounding in the logic of this argument for not getting the influenza vaccine this year, nevertheless, as this person is telling us this, in the back of our minds, we're trying to avoid the elephant in the room, which is that influenza vaccine is actually not as effective as we'd like it to be. So there is a small possibility that, yes, you got the flu vaccine and you still got influenza. That is a very real possibility. Nonetheless, you should still get influenza vaccine. So I'm just going to skip this in the interest of time because this is probably not going to work. So there are several factors that have been implicated in influenza vaccine performance. And I can tell you, before I even get into the discussion, that it is complex, multifaceted, very difficult to study because of a lot of confounding variables, and incompletely understood. But I just wanted to give you a flavor for some of the recent literature in this area because I think it's fascinating about how we think about influenza vaccine effectiveness studies going forward. So there are vaccine factors, for sure, things like whether the vaccine matches the strain that's in the community, how you give the vaccine, and then production-related issues. And I'm going to focus on this production-related issue as just one of the components of vaccine factors for this presentation. So in order to talk about that, I need to discuss how influenza vaccine is actually manufactured. So in February, the WHO gets together and decides which strains are going to be in the influenza vaccine for a given year. So for example, the vaccine that we are getting now as healthcare workers, the composition of that vaccine was determined 7 months ago or 8 months ago in February. Once those viruses are selected, they are inoculated into millions of chicken eggs in the springtime. And then in the summertime, those viruses are harvested, inactivated, and their subunits are purified, so hemagglutinin and neuraminidase. And then those purified subunits are put into vials, prepared and packaged for delivery at the start of influenza season in October. Now, there's a potential issue here with this step of the manufacturing process where we're inoculating human viruses into chicken eggs, because you might imagine a scenario where the virus could adapt or revert to a strain of virus that grows better in chicken eggs than it does in human beings. And if that egg-adapted virus induces antibodies that are less effective than antibodies against the human virus, that could be a cause of decreased vaccine effectiveness in us. So these investigators decided to look at that question. So they noticed that in 2014 and 2015, basically all of the circulating H3N2 viruses in the United States had acquired this new mutation at position 160. So that arose in 2014, 2015, and since then, almost every H3N2 virus has had that particular mutation. Now, it's worth noting that the old version of the virus, which I'm going to call K160, actually grows more readily in chicken eggs than the new version of the virus. Okay? So if you think back to what I just told you, it's possible then if you inoculated the T160 virus into a chicken egg, that it would revert back to the K160 virus. And so if you had a vaccine that had the T160 virus in it, supposedly, you might end up actually generating antibodies against the K160 virus because that's what actually grew in your chicken eggs. So they decided to look at this. So they compared antibody responses to different types of influenza vaccine, comparing non-egg-based vaccines and then egg-based vaccines. So in this graph, they looked at the vaccine's ability to mount antibodies against the K160 virus. And you can see that all of the vaccines were pretty similar, which makes sense. But then when they looked at whether the vaccines could elicit antibodies against the T160 virus, you can see that the egg-based vaccines were substantially inferior to the non-egg-based vaccines, which lends credence to the hypothesis that in the egg-based vaccine, that virus actually reverted to the old version of the virus and therefore generated antibodies against the wrong strain of the influenza virus and therefore contributed to the decreased vaccine effectiveness in that year. So there are also a variety of host factors that contribute to suboptimal influenza vaccine effectiveness. I'm going to talk about just a couple of them right now. These include comorbidities or concomitant medications that affect immune response, as well as this kind of emerging concept of immunologic priming, meaning your history of influenza infection or influenza vaccination could have an impact on your long-term responses to future influenza vaccines. So I wanted to mention these kind of handful of studies that have been published about the impact of statins on influenza vaccine effectiveness. So statins have kind of very potent lipid-lowering properties, but as we know now, they also have this kind of pleiotropic anti-inflammatory and immunomodulatory effects. So one might hypothesize, similar to other immunomodulatory drugs like steroids or disease-modifying anti-rheumatic drugs, that people who are on statins chronically might have an attenuated response to influenza vaccine. So these investigators looked at that question by analyzing a randomized controlled trial of influenza vaccine in elderly adults. And in this table basically is the ratio of the antibody response in people who were not on a statin to people who were on the statin. So if the ratio is greater than 1, that means that not being on a statin was superior to being on a statin. And you can see that basically regardless of the influenza strain or what type of statin you were taking, whether fermentation-derived or synthetic statin, not being on a statin was associated with a higher antibody response to influenza vaccine. Now, subsequent to this study, there have been a number of other retrospective analyses looking for an association between chronic statin therapy and clinical outcomes. And basically, everything that has been published suggests that chronic statin therapy is associated with reductions in flu vaccine effectiveness against medically attended acute respiratory illness, laboratory-confirmed H3N2 influenza, influenza-related office visits and hospitalizations. So this sort of corroborates the antibody data that I just showed you. Now, obviously, this has not translated into any sort of policy recommendation about what to do with statins and vaccinations, and it should not, because these are all retrospective analyses that are limited by residual confounding. So, for example, people who are on statin therapy likely have other comorbidities or health behaviors that might affect their response to influenza vaccine, or might affect the way that they seek care if they get sick with a disease that's like influenza, which may impact our ability to detect whether they are coming to the hospital for influenza or not. And so prospective studies, I think, are needed to answer this question more definitively. But nevertheless, it is interesting given that nearly 50% of the population over the age of 65 is on a statin. So I'm going to turn now to this concept of immunologic priming. So this is a concept where basically, what influenza viruses you have been exposed to before in your life, or influenza vaccines you've been exposed to before in your life, could have an impact on how you respond to influenza vaccine now. So let's start by talking about prior year vaccination. So a lot of studies have suggested that getting influenza vaccine in multiple years in a row might actually attenuate your response to influenza vaccine this year. So for example, if I got flu vaccine for 5 years in a row, my response to flu vaccine this year might be attenuated. Now, what would be the immunologic basis for this? So that's incompletely understood. One hypothesis is this concept of original antigenic sin, which is basically, at some point, maybe 10 years ago, I got an influenza vaccine, maybe my first influenza vaccine. I developed an antibody response to that vaccine, but that antibody response has subsequently shaped my antibody response to every influenza vaccine that I have gotten since then. So that when I get a vaccine now, I end up stimulating a memory response to that original influenza vaccine, which ends up eclipsing any antibody response that I can have to the new vaccine, and therefore I don't develop any new antibodies to this new drifted antigenic variant of influenza. And so my vaccine effectiveness is lower. So there's been a number of observational studies to look into this question because I think it's really interesting. Probably the one with the best the best illustration of this was this observational study from the Marshfield Clinic in Wisconsin. So this site has been doing community surveillance of influenza for the last 15 years, and they compute vaccine effectiveness for influenza every single year. And so they did an analysis looking at vaccine effectiveness and stratified their population by whether you got flu shot this year or last year or not, and also if you are frequently vaccinated or not over the last 5 influenza seasons. Okay, so I'm going to show you their data now. So here they basically just compared if you got flu shot this year and last year, or just last year. And you can see that the vaccine effectiveness estimate was actually pretty similar for all 3 groups. So this doesn't really support the hypothesis that I've just been trying to sell you. But then they broke down this data a little bit more by looking further back and seeing what was their vaccination history over the last 5 years. And you can see basically there was a nice dose-response curve, or lack of dose-response curve, in that the less frequently you had been vaccinated over the last 5 years, the more effective was your vaccine in the current year. to the point that if you were vaccinated every year for the last 5 years, this season's influenza vaccine was only 24% effective, compared to if you had never been vaccinated before and you got this season's flu vaccine, it was 65% effective. Now, before you conclude from this that you should only get your influenza vaccine every 5 years, I should point out that this was nonetheless, all of these groups were superior to not getting vaccinated at all or getting infrequently vaccinated in general. So we still recommend annual influenza vaccination, though this is an interesting finding, and it's thought to be heterogeneous between studies because